Uh, so good evening, everyone. My name is Dr. Jonathan Moreira. I am Associate Professor of Medicine at Northwestern University's Feinberg School of Medicine. I'm a hematologist oncologist, so I focus mostly on cellular therapies, stem cell transplantation, and CAR T cell therapy, but I'm also a lymphoma specialist. And I wear a few hats at the university and at the medical school. But I'm also vice president of the Medical Organization for Latino Advancement, and we're really excited to welcome you today to our webinar focused on family medicine as a career path, addressing disparities and securing a pipeline of Latino, Latina, Latine, LHS plus professionals in family medicine. So I am very honored to introduce our speakers who bring a wealth of knowledge and passion to this field. And hopefully this can generate a fantastic and robust discussion and questions from all of you as the participants. So we have two speakers today. The first one is Dr. Leah Petruccelli. So she's a third-year family medicine resident at Advocate Illinois Masonic. She is originally from Connecticut, but Dr. Petruccelli moved to Chicago in 2017 to complete her medical training and has been here now for almost 7 years. She's passionate about health equity and integrative medicine and how the two can intersect in her work as a physician. In her free time, she enjoys playing basketball, jujitsu, dancing, surfing, and traveling to different national parks. Our second speaker is Dr. Majed Abbas. I'm sorry, Dr. Abbas, if I pronounced your name correctly, or is it Majed?
It's Majid.
Majid, Dr. Majid
Majid.
Abbas. Thank you for correcting. My last name always gets mispronounced, so I want to be very sensitive to that. So Dr. Abbas is a third-year resident in the family medicine program at Advocate Illinois Masonic Medical Center. He's born and raised in Boston and spent the last 7 years of medical training also in Chicago. He's a passionate advocate for health equity, leadership in medicine, advocacy, and working with underserved populations, both in Boston and here in Chicago. He spent time volunteering at each level of training, including helping to run a free clinic during medical school. His current co-chair of the ABIDE Committee, it's a Diversity, Equity, and Inclusion Initiative at Advocate Illinois Masonic Medical Center, Family Medicine program. He's been a part of establishing a curriculum for residents to learn about the populations they serve and how to be better patient advocates as part of being a physician. He's currently applying to jobs on the East Coast that will align with the mission to have physicians continue to lead the charge and to improve healthcare for all, both in our communities and beyond. So please join me in welcoming Dr. Petruccelli and Dr. Abbas. I will be here present. I've got some lingering responsibilities on the inpatient service and in my clinic. So I will cede the floor and the platform to Dr. Abbas and Dr. Petruccelli, but I'll try to monitor things from afar. So excuse me while I do turn off my camera and my microphone, but really very excited and honored to have both of you here. So without any further ado, please take it away.
Thank you, Dr. Moreira. We appreciate it. Hi, everybody. I'm Majid. This is Leah.
Hi, everyone.
We're on the same camera, so we're going to be nice and cozy, but we hope this is a very relaxed, informal space. Obviously, we'll give you a formal presentation, but we do want you all to feel free to ask questions. This is kind of your time as well. Sorry, there's a cat that's just wandering through, and he's vocal. But we do want to make this space open for you all to ask questions, and we want to be resources for you here as well as give you some information. So feel free to stop us at any point. Hopefully the presentation shouldn't take too long, maybe maximum like 25, 30 minutes. And then that way we can just have time for questions and just open dialogue about whatever you all want to talk about. So without further ado, I will go ahead and share my screen.
We'll also try to monitor the chat. So if you don't want to speak up, we can have you guys write questions down that we can answer as we go as well.
Sorry. Okay, so our presentation is titled Medicina de Familia as a Career Path and Addressing Disparities and Securing a Pipeline of Latinos in Family Medicine. All right, so who are we? So you've heard a little bit about both of us. We're going to just take care of the cat really quick. You've heard a little bit about both of us. I think both of our bios are pretty encompassing of who we are and kind of what we have been dedicating ourselves towards during our training. Obviously, we want to be the best physicians that we can be, but we've really tried hard throughout both of our training to become better versed in health equity, the health disparities, social determinants of health, advocacy, really trying to do more. Because I know for me personally, I do believe that our roles as physicians have a higher responsibility than just doing the medicine portion. We do have we have this standing then platform that we should be able to use, and that should be like just as important as the medical care that we do give, because all of these things kind of play into our roles. I don't know if you want to add anything.
Yeah, just going off of that, using our voices at a table to realize who isn't at the table and who we need to get at the table. So that is one of the reasons that inspired us to join MOLA, and we're so excited to talk to all of you.
Yeah, and we also are, I think Dr. Moreno mentioned, I'm the co-chair of our DEI committee called Abide. Leah is the other co-chair. So we do this stuff all the time. So yeah, like we are very excited to chat with you all. All right. So some objectives to understand the principles, practice, and impact of family medicine, identify the common health issues and disparities in Latinx patients, and identify career paths for family medicine practitioners, and then understanding the value of cultural and linguistic concordance in family medicine serving Latinx patients.
Okay, so we'll start with family medicine. This is a specialty also known as primary care. It combines multiple types of doctors into one. So we basically see cradle to grave medicine. So that means from newborn to seniors and everything in between. We're able to participate in delivering babies, prenatal care, women's health procedures. We can do other procedures, including dermatological procedures like skin biopsies. We can do knee injections, and basically anything that you want to get extra training in. You can learn how to do ultrasound. The world is your oyster. And then in terms of the settings, we can practice in the hospital or in a clinic. You can do both. You can work in a rural town or in a big city. And again, everything in between.
All right. Questions about family medicine as a whole before we move forward? Just kind of what we do. Feel free to shout them out or put it in the chat. I just want to make sure we have a good base before.
Can we see the chat?
I don't know. We can try. Okay.
Hi, sorry. I was wondering, I have a question. Can you hear me?
Yeah.
Yes.
Okay, sorry. Hi, my name is Sarah Medina. I'm an M2 at UIC. So I'm just trying to figure out specialties, and family medicine has been something that I've been thinking about. So I was just wondering, like, in a way that, yeah, you're trained to like kind of see from like babies to older adults, but like in the future, like, can you ever kind of like focus your patients to be like something else? Like, if I eventually like wanted to stop seeing like babies, like would that be possible? Or like, are you able to kind of make that age cutoffs for yourself, or like how does that work? Or do you have to kind of always do that?
That's a great question. I think that the cool thing about family medicine is you have the option to see everything, but you can definitely narrow your focus. So I know a lot of physicians that only see 18 and older and they're family medicine docs. I know a lot of people that still want to see kids. You can also go out on your own and do an adolescent only clinic. So you have the ability to narrow your focus. You could also just see women and children. You basically market yourself as the type of physician that you want to be. So once you graduate residency, you can seek out a job that sees the patient population that you want, or as you get out on your own, you can market yourself and then it kind of self-selects. So you definitely don't have to see kids if you don't want to anymore. And then if kids and children are what you want to do, then sometimes you have to go out in a more like rural space or in an academic space that still trains to see newborns and kids, but you definitely don't need to keep doing that. And then we have another question from Daniel. Feel free to unmute yourself and ask.
Hi, my name is Daniel Velasquez. I'm a pre-medical student at UCLA, and I guess one thing I've just always wanted to figure out, obviously I have a way to go from now, but what made y'all pick between family medicine and a med peds program?
So med peds, I think, focuses heavier inpatient. That's always a big push for med peds, which was difficult, I think, for me. Like I didn't really want to spend as much time in the hospital. Med peds also gets like way more specific, I think, into like medicine and peds. So you're doing a lot more like intensive training in both of those. And then I don't feel as I didn't feel personally that it would allow me to pursue the other things that I was interested in outside of like my medical training, which is really important to me. So that was kind of why I chose this route.
Does that answer your question? Do you have any follow-up questions?
No, that answered it perfectly. Thank you.
Okay. Then we have another question in the chat from Danielle Sanchez. You definitely have the ability to do emergency medicine. It's definitely in those smaller rural areas, like you said. And what you can do is if you're in residency, you realize that you want to do emergency medicine, you can use your elective months, which are basically months you create. Most programs have those months. You can use those to work in emergency rooms, in ICUs, to get that extra hands-on training and intubating and other life-saving procedures that we don't get super well acquainted with throughout residency. So it's basically your comfort level. But as someone that is getting emails every day about new jobs, there have definitely been a lot of emergency medicine opportunities that have been sent my way. And then I think your second comment about working at nights when you're older definitely is true. And I think the cool part about family medicine is you have the ability to pivot. It just the matter of maintaining your scope and skills and deciding what do you want to make sure you can do. So if you started to do family medicine and you wanted to do emergency medicine, maintaining those life-saving procedures and skills so that you could always do that, and then you could pivot whenever you wanted to.
And then a lot of family medicine, if you do like the ER sort of setting or like acuity sort of stuff, but maybe a little bit less, urgent care is a big one where you can do similar things. I mean, not as intense, but a lot of family docs end up doing just urgent care work. So that's another path, and we can always talk about that too. So I think we will move on to the next bit. So in terms of like advocacy in family medicine, there's a lot of different, as we do a lot of things on the medicine side. Wear a lot of different hats on the medicine side. We wear a lot of different hats outside of the clinic and the hospital too. We're advocates, we're teachers. We coordinate care for patients outside the hospital, inside the hospital, in their communities. We're helping to navigate a lot of difficult processes for them. We are, detectives for health disparities. At our clinic, for example, we have a screening tool where we kind of ask questions about social determinants of health, and we ask about patients' living status. We ask about, how long it takes to get to the clinic, how they get to clinic, do they have enough food at home? We ask these sorts of questions, and we kind of try to see like what are some of the barriers that our patients face. Same, that kind of ties into being social medicine specialists. We do work with a lot of different parts of the medical infrastructure. Like we have our hands in pretty much everything, or we can get our hands in pretty much everything. And that leaves us in a great place to be kind of the quarterbacks. We can navigate everything. We help patients get to where they need to go. We set them up with the right specialists. We talk to those specialists. We coordinate everything. We're kind of in charge of everything that our patients need to be there at their healthiest. And then these are some of the health disparities that we've identified specifically in the Hispanic Latino population. So in terms of like cultural and communication wise, so 44% of patients say that communication problems from language or cultural differences, that's a major reason why they have generally worse health outcomes than other people, other adults in the United States. 17% of Hispanics and Latinos live in poverty compared to 8.2% of non-Hispanic whites. On top of that, 53% are more likely to work in a higher risk job environment. And in those, and given that accidental injuries are such a big number of like injury and death in this country, they actually experience, that's the third highest cause of death in Hispanic Latinx patients, with them being 3 times more likely to die in a work accident than their than their non-Hispanic counterparts. All right, could you all make sure that you're muted when you do sign in, please? Thank you. And then the last thing is insurance status. In 2020, 18.3% of the Hispanic population was not covered by health insurance, compared to 5.4% of the non-Hispanic white population. This is per the U.S. Census Bureau. All this stuff's from the U.S. Census and surveys that have been conducted by independent research institutes. So I think this goes to show on a pretty extensive basis that these are things that are impacting the health of the Hispanic Latinx communities. Okay, so what solutions we have?
Okay. So before we go into solutions, does anyone want to share anything else that they've experienced either with their family members or what they've learned about through their schooling in terms of health disparities or health inequities? Feel free to write it in the chat, or you can raise your hand again. Otherwise, we'll just move forward. Let's see. Okay. Just to take a step back, we're just seeing Jocelyn's chat, so this can give anyone time to think of something that they want to share if they do. So Jocelyn, to answer your question, the difference between internal medicine and family medicine is that we see a broader population of patients. So like we were talking before, we see patients, pediatric patients, so 18 and younger. We also do women's health procedures and can do deliveries. We can do prenatal care. So internal medicine is adult-only medicine. You can do in the hospital and outside of the hospital, like with family medicine, but you don't get training in pediatric and newborn care as well as OB. So if that is something that's important to you, family medicine would be better. But if you know you never want to see children, internal medicine is a great route to still do primary care.
And internal medicine does more inpatient work than family medicine does, for sure.
Okay, so then moving on to solutions, there are a number of things that we can do to address these horrible, horrible disparities that exist in both our world as well as specifically in the healthcare system. So pipeline work is really important. So connecting to mentorship and people that are still in elementary school, middle school, high school, to introduce them to STEM fields of science and medicine specifically, and then doing lots of work to promote awareness and education. So a lot of the things that we do in our residency program is adjusting our education, so our curriculum for our conferences that we have weekly, as well as holding other meetings, and making sure that we are trying to incorporate the most equitable education so we can serve the patients that we're seeing. And then we discussed mentorship, and then scholarships are a big thing. So there are a number of scholarships that are either grant funded, state funded, or privately started that can help support people that are underrepresented in medicine and help overcome the many financial barriers there are to get into an MD or DO school. Nope. Okay.
Okay, cool. So more about scholarships, financial aid. Starting early is really important. So, you know, if you know you want to apply to med school, if you know you want to apply to anything really, like starting early and looking is the best way to start. Looking at the specifics is going to be really important. This path is very expensive. And that's kind of the biggest thing that no one really talks to you about along the way. You know, you pay for things like board exams, you pay for the MCAT, this is the pre-med, test that everybody takes prior to entrance to med school. You're paying for, you're doing a lot of volunteer opportunities, so it's unpaid work that you're doing. So in order, so finding out how much each step will cost you is very important, as well as kind of budgeting and kind of planning to apply for scholarships, looking into things that you're interested in, that you can get a scholarship for to help you towards this path. Those are kind of big parts of it. And then FAFSA also is a way to apply for aid, and you can get aid that way from a lot of institutions. So those are all important aspects of kind of, as you're planning to go into medicine, is looking into anything that can help you along the way. Like personally, I had to struggle for everything. My loans are way higher than a lot of other people that you find in medicine. I think there was a statistic that 75% of medical students are from like the higher levels of pay within, like they come from families with higher levels of pay. And to me, that was always a difficult aspect of this training, was that I had to take out loans for everything that I did. So it is something that I wish I knew before, like, oh, hey, there's scholarships that are available for X, Y, and Z things. And it's really important to do that research before you get started.
And then you could apply for these scholarships, and then you could also ask your program for funding for certain things. Some residencies will pay for boards exams, some med schools will pay for board exams, some have scholarships along the way throughout college, med school, residency. So even if you don't get a national or state or your specific program scholarship, you can ask for sources of funding. So these nonprofit hospitals have many tucked away sources of funding that they aren't going to advertise, but if you ask for them, there's a chance that you could get something covered. So keeping a list of those costs, and then when you're either applying, asking for them, or throughout the process of schooling. We have a question in our chat from Danielle saying, I've heard of fellowships and full ride scholarships for med students intending to work in primary care. Are any of you in those programs? If so, do you mind talking about access to those programs?
I don't know of any of us that are in them. I don't believe so. I know that those exist as well. I've heard of those. Sometimes they're at certain, maybe I think they're only at certain programs that do that, certain medical schools as well. I will say, if people are interested in primary care, when I was in between my first and second year of medical school, I did the National Medical Fellowships Primary Care Leadership Program. I knew I was interested at that point in primary care, and that was kind of like a summer course where they paid me like a stipend. I got to do a research project. I got to shadow some doctors at a community health center in the Boston area. So those sorts of programs are available, and that was something that I did. So there are a lot of those programs that, if you are interested in primary care, people want you to be interested in primary care. They want you to learn more about it, and there are scholarships and like paid opportunities, especially in med school, and probably before, but definitely in med school. Right.
Okay, and then these are just some other scholarships that help support people in medicine. So as Madge said, the National Medical Fellowship is one, and then there are many others that are out there. The Dream.us is for specifically people that are undocumented, and then the rest, you can continue to just search. And if you have a niche that you think that would work for a scholarship, you can also search it specifically, and then just look at the eligibility requirements, because they're usually there, but they're easy to get to. And then we will definitely be emailing this slideshow to you later, so you don't have to worry about taking notes. I'll send it to the head of MOLA, who can distribute it to you.
All right. And then mentorship. I think we talked a little bit about mentorship, and it's very important. I think along the way, for a lot of medical students, especially if they don't have a family member that's in medicine, they don't have someone that they know close to medicine, it's really hard to navigate this path, navigate the next steps. Even when you get into medical school and residency, there's still things that you're just like, oh, I wish I had someone that knew X, Y, and Z things. So talking to as many people as possible about your interests, and meeting people at every level that you can, at every step that you take, is a great way to find those mentorship opportunities. Just talking to people gets you a lot of places, and it could just be as simple as one conversation, and you're finding someone that you can just connect with and work with for a long time, because you really do never know if you'll be connected to who knows who, especially at this point. If we know somebody and we can connect you to that person, and that person connects you, it can be a cascade. So it's really important to talk to as many people as possible.
And then in the chat, a lot of people have added some other scholarships out there. So thank you for sharing. Continue to share any links or things that you think would be helpful. And we can try to add them to our PowerPoint as well. But in addition to talking about things, sometimes it's helpful to like frame a problem in your mind where you say, okay, this is the major barrier, whether it's the application to med school, and this is what you're really passionate about. You can combine those when you're talking about them. People generally want to help out. So it is really a good way to kind of seek out that that mentorship or that opportunity. I know for me, talking about being involved in integrative medicine is specifically underserved. I got connected through a colleague to someone that is now potentially connecting me to a job of doing integrative medicine for underserved patients. So it's one of those things where just a simple conversation can get you an opportunity that could be life-changing. So I was thinking it would be a good idea to practice if we could talk about your passions as well as things that might be barriers. So if anyone wants to either write in the chat or raise their hand and talk about something specifically within primary care or outside of primary care within the social medicine world that you're passionate about, we could do that. And then I'm just going to check the chat really quickly. You know the answer to this one?
Yeah.
Okay. Do we have any volunteers?
I can share a little bit,
Okay.
if that's okay.
Yeah. Go
Yeah.
ahead.
Yeah, hi, my name is Priscilla. I'm a first year at U Chicago. And I think one of my passions within like a lot of what I've seen growing up, like in terms of like mental health barriers within the Latino community. So I know we talk a lot about like access and stuff like that, but even just the quality of the resources, the availability of like providers within mental health care fields that are Latino as well can understand the cultural components and things that patients bring in from that community, as well as like this how like spiritual health and physical health all come together within our mental health, and how that's how we traditionally look at mental health doesn't always have to be the way that we support our patients with just like starting conversations with medications and stuff like that, but being able to understand the patient as a whole person.
Yes, that is wonderful. Thank you for sharing that, Priscilla. And I think that's something that is so cool. When you have a specific passion, you talk about it, people get excited listening to you. So just listening to you talk about that made me think of all the different opportunities that there is for that work, and programs and other doctors, physicians that are working already get really excited when they have people that are really passionate about an issue. Can think of different ways that we could solve it. So thinking about filling the gaps and having more representation of people of color that are mental health providers is huge. And something that you could like go to med school or residency and build a committee on. So I think just talking about them and being really excited about it is a really good way to get involved with things that you're really passionate about. Anyone else want to share? And then while we're waiting, in terms of answering your question, Andrea, about how important is it to have publications to match in family medicine? I think that being involved in some form of research is helpful, especially for the more academic institutions. So for example, in Chicago, Northwestern or U Chicago, they're probably gonna want you to have some form of research, but I'm not sure it's necessary to have something published. Would you agree with that?
I would agree with that. I don't think you need really too much at all. I think I had like 2 things just from work that I'd done in undergrad and like grad school. So really it's nothing super extensive. Having some sort of interest, I think, you do need some research along the way at some point, just given how everything is competitive, like research is very important, but family medicine is probably one of the fields where it's the least important, I
Yeah.
think.
And it can be like quality improvement
Yeah.
things, like working with patients,
Mhm.
even going back to Priscilla's passion. Like if you were to do a study in whatever organization you work in and of the need for people of color in mental health or cultural competency in mental health, that could be a project that you did. And then you could present at a conference, and even just having poster presentations will look good on your resume. And then we have a couple people that have shared specific interests. So we have weight loss medicine, we have non-alcoholic fatty liver disease, as well as its impacts on pediatric Latino populations. And then let's see, improving communication between providers and limited English proficiency patients was really great. And then several people have shared some other mentorship and scholarship links. So thank you for everyone that has shared them.
Yeah, if anyone has questions about the link that Priscilla posted, because I did that program, feel free to ask. I can also leave my email if anyone wants to ask about that.
Yeah. I will put our emails in the chat now, just in case anyone has to hop off early. Do you have any numbers in yours? Okay. Does anyone else have any questions before we move forward? Okay, thank you all for sharing your specific interests.
All right, so like we talked about a little bit, representation is very important, both for for health equity in general and for our patients. As I think a lot of us probably know, it is not an equal playing field right now. It many people have doctors in their family, parents are doctors. It really just gets like kind of passed down through a lot of people. A lot of medical students are white as well, which is another big aspect of it. So these are things that we are actively trying to combat. I think a lot of medical schools are trying to combat that, but it's still a very big problem, and that also kind of bleeds into our patient care as well, because our patients want to see someone that looks like them or speaks their language. Just it makes them feel safer, it makes them feel more like able to share and open up and express themselves. That's very important as well. There are nuances to care and to culture that some patients may like, that some providers may not understand because they don't come from those backgrounds, haven't learned about those backgrounds. So, I mean, I think Lee and I probably have just billions of examples that we could throw out right now if we really wanted to. And so it's really important to see our patients, like ourselves reflected in our patients, and vice versa. I think that's a big part of this. And just to touch on a couple of things we've already touched on, the financial burden and the educational opportunities are way less than they should be. So hopefully this has helped at least identify a couple other ones that you all could use just along the way. And hopefully we can continue to build more of a database and get this out to as many people as possible, so there's more awareness, because I think awareness is probably the biggest thing that is lacking. It's just not knowing some of the things that are out there and how to look for them. All right. So more about career paths in family medicine, which I think we can both touch on. But like we talked about a little bit, you can do full-time, you can do part-time, you can do inpatient, outpatient, so in the hospital, outside the hospital. You can do some inpatient, some outpatient. You can do full-time advocacy in public health. You can specialize in a bunch of different things like sports medicine, sleep medicine, obesity medicine, integrated medicine, which we're both doing, addiction medicine. You can go to academia and leadership, which I'm interested in doing. So there are a lot of different ways that you can go. Some people, get their medical degree, get their family medicine degree, and then never see a patient again. Some people see 25 patients a day and do that for 30 years. So it really just depends on what you're looking for. And family medicine gives you a really big scope, and you can kind of narrow that and fit that to whatever your interests are.
Yeah, and I think the ability to change as well as do a number of things helps prevent burnout in the career. So I think that when I was looking at primary care, I didn't know 75% of what family medicine doctors could do. I thought they were only in the clinic. So I think that that's something that needs to be taught more fully in med school, and also before, just to know like you have the option to do things. And specifically going back to the med peds question of med peds versus family medicine, you probably could do the same thing that med peds could do. It's just a matter of bolstering your training with more inpatient medicine. But I think that just it's helpful to know the different avenues that you could do. Does anyone have any further questions regarding family medicine as a career path and what you can and cannot do? Okay, I
I
see
have a
that.
quick,
Oh yeah, Priscilla, go.
sorry, I just had a quick question about when it comes to like, I know I've met folks who are also in academia and are also like deans and family medicine or lead like their own clinics and the combinations of stuff. Do you mind touching upon like also just like economically, like how that looks different? Like if it's like you're working more clinical time, do you typically get like, are you someone who are paid more, or if it kind of varies per per combination of stuff you're doing?
So I've done a lot of digging into this because I'm very interested in leadership in medicine and plus or minus academia, depending. But the biggest thing it's going to pay in a lot of places is seeing patients. However, there's also the times where people get into higher levels of leadership and get paid more for that, depending on the system they're in. So I would say it really depends. And it really is about advocating for yourself and finding a place that will allow you to feel good about the work that you're doing. That's the best way to answer that question. If you're in a place that will allow you to, like when I've been looking into jobs, I've been able to kind of negotiate, be like, hey, I want more administrative time to work on X, Y, and Z, social determinants of health things that I'm interested in, or I want to see this certain subset of population, this certain subset of patients. I want to see more of these sorts of patients, and places are willing to work with you on that, and then not really changing salary structure as a result of that. But it really depends on how the system that you're going to work for, or the clinic that you're going to work for, or the hospital you're going to work for, how they set up their payment system, their payment model. There's so many different kinds of payment models out there, which I'm happy to go into as well. If people really want to hear about that, it is a little bit dry, so we can definitely talk about it if you want to talk about it, if you have questions. But I would say doing something that really aligns with what you want to do and what you're hoping to get out of this career is the most important thing. And then, finding a place that will pay you appropriately for that, and not being afraid to ask for, an appropriate salary, because, you do deserve that after all the work that you're putting in. So, does that answer your question? Oh,
Okay.
okay, great.
Thank you. And then also you can expect to make at least a six-figure salary as a family medicine doctor, and it'll vary depending on if you're at a federally qualified health center, which is the type of center that is nationally grant funded to see patients that don't have insurance. Those typically pay less, but have the ability to be more rewarding. And then you have the option to do part-time work where you can do other things that you're interested on the side, and then you can ask for loan forgiveness because you will graduate with certain loans. So taking a lower paying job might seem less of an opportune decision, but if it's what you love, like Madge was saying, I think doing something that you're interested in is way more important to prevent burnout. But you can ask for other things, including like a sign-on bonus or loan forgiveness per year. There are options. So I think if the biggest takeaway that I would say, if you can remember anything from us, is just asking questions and asking for things, because you could always be told no, but at least you know the answer and you know the opportunities that exist.
And I'll definitely add that, once, obviously, as you're going through the training process, as you're going through applying to med school, as you're going through applying to residency, it feels like such a competition, and you're, trying to make your best impression and all these things. And of course, you want to do that no matter at what level. But you feel like you're the one that's always chasing after the desired place. It kind of flips when you're applying for jobs, especially in primary care, because they really want us. So it is important to know that your worth and make sure that you are asking for your worth, like asking for things and not being afraid to ask for things, because it is about your happiness and what you want as well. It's about matching up a lot more than it is kind of like during the med school process and residency process. We're just trying to get somewhere that you really want to go. This is more about like, okay, I have options. Like, why this place? So you kind of become the desired entity, which is pretty cool once you get to this point. So
Yeah, it's a nice switch.
it's a nice switch. It's a nice switch. Absolutely. Steps. I love that.
Okay, Daniel, I believe you asked a question. You asked if I could touch on integrative medicine a little bit more. So in terms of my interest in that, that's kind of started before deciding I wanted to be a doctor. I shadowed a lot of different alternative medicine practitioners. And so the way that works in the family medicine field is you can either study it in residency, in med school. After, there are a number of courses you could take that are either online or in person. And then there's the integrative medicine fellowship that you can do. There are several residency programs that have a 200-hour online course called Integrative Medicine in Residency. That's through the Andrew Weil program that started the Integrative Medicine Fellowship. So you have access to a lot of information that you can incorporate in clinic. And then in terms of doing it as a career, I think the biggest thing is time. So asking for the ability to increase the time for your patient appointments so you can do those, or group visits. So you can start group visits where you do like medical acupuncture or a behavioral health group or a diabetes and nutrition education group. So there are a number of creative ways to do that. And it is way more common and popular to do it in family medicine. So you can search for those places to see those models or create your own. Do we have any other questions regarding family medicine as a career path or anything else that's come up? I think this is our last time.
This might be our last. Nope, that's it. That is our last time. So these are some resources, and these are our emails. Again, we'll make sure that Jocelyn gets this presentation,
yeah.
of course. And then we have a question. When did you decide that family medicine was the right specialty for you? I would say it was, I'd already I guess had it on the radar second year of med school. And first year of med school, honestly, it was kind of already on the radar. After I was going through my rotations, I think family medicine was like my fourth or fifth rotation in third year of medical school. And I really think it just felt like my people. It felt more like people that were passionate about the same things that I was passionate about, that wanted to do the sort of work that I wanted to do. Obviously, the broad scope was very nice, and I'm someone that likes variety. I'm really big about preventing burnout, so anything I can do to prevent burnout in terms of doing different things was really part of that. And I didn't really mesh with internal medicine or surgery because I didn't feel like they were too inpatient heavy. They didn't focus so much on the people aspect that I really wanted to focus on. So that's kind of how I got there.
And then for me, I worked as a medical scribe for a primary care office before med school. So that really helped shape what I wanted to do. I was able to see a doctor that had been practicing for 3 decades that had wonderful relationships with all his patients, and just got to know the families and see everyone. And I really loved that. So then I was connected through a family medicine leadership program in med school at Rush, where I was able to work with a family med doc from day one of med school. So that just further affirmed that I wanted to do it. But I think it is really hard to know what you want to do even at the end of med school as an M3. So being able to talk to a lot of different attendings and people that are doing it to see if this feels like what you'd want to do, and then asking them what's their favorite and least favorite part of their job. And if the least favorite thing doesn't seem like a deal breaker for you and the most favorite thing gets you excited, then you know it's for you.
So next question is, would also like to know how you went about finding a residency. Want to be in a program that serves the Latino community in its full scope. Yeah, so a lot of that, definitely in the Chicago area, there's a ton of programs that do full scope and serve the Latino community, and really asking questions and doing research online using the ARIS websites, which will be the thing that you apply to residency with. That has a lot of resources there. There's the Frida website also that they use to advertise programs, but really just doing your research and looking into you can find programs that offer all of that. So it really is just about asking questions, looking on websites, looking at Instagrams, using the information. There's a ton of information at hand that we can that we can use, and using as much of that as possible is going to be the best way. And if you want to go somewhere warm, I mean, there's options. You got options. I know they do a lot of good work in full scope work in like Texas and California. So those are really good options as well.
And it's a perfectly okay question to ask, like, what are the demographics of the patients you see, and break them down per race, age, socioeconomic status. Like, that is a very welcomed question and very appropriate question to ask during the residency process. It's kind of hard to figure it out before you apply, but if you see programs that write things about focusing on underserved care, then it would probably be a good match.
Yeah.
And then we have a question from Priscilla. I'm wondering if you all know more about programs that do dual residencies, such as family med psych programs, and our thoughts on them. I know there's a great one in Iowa City. I don't know much about the other program specifically, but I have a really close friend that's at one of those and is really loving it. I think the major thing is it's a bigger time commitment. So family medicine residency is usually 3. There are some 4-year programs out there. The dual ones are usually 5. And they just do more rotations on each. So I think if you know you're passionate about family med and psych, it's a great option to do it. And then thinking about what you want to do after. So connecting with people that have graduated from those programs and asking if they feel like it is helpful for them. But I think if you know that you care about those things, it can only benefit you to have more rotations in each of them, because I think there are times where you would do the family medicine residency and then want to do a fellowship in there, and that's more of a matching process. So I think the biggest difference is your class would be smaller. So family medicine residencies usually are between 6 and 14 people per class, but the dual ones are usually like 2 to 4 per class.
Yeah, and there are a bunch of them. I know there's one in Boston University. So I don't know too much about it, but there are definitely a lot of opportunities there if you were interested in it. I think interest is the biggest thing. It's like really looking for things that match your interests and go and not being afraid to ask questions. That's going to be the best advice that we can give you, I think. And then I think there was a comment. Danielle said, I work with Kaiser Community Medicine residents at UCLA, and they all do amazing work in homelessness and community health. That's awesome. I've heard of a lot of good things about that program. So that's awesome. Yeah.
Yeah, thank you all for being so active and sharing. I think it's really helpful, and we all probably have a lot of similar interests, and we don't know about all of them. So thank you for sharing them with people.
Yeah. Makes it more fun for us to talk to you all as well. So
yeah.
Any other questions? Any thoughts? Burning question? Anything at all? We do want to be respectful of people's time, so we got about 10 minutes. But if you all don't have any more questions, we can also end early. Whatever you all want, we are here for you all. Right. If there's nothing else, I will stop sharing here. And oh, we got another question. Oh, okay. What is one of the most important things to match in family medicine in regards to the CV? I think the biggest thing I would say is honestly just volunteering on things that match your interests and that match, like if you want to do family medicine, shadow at a family medicine clinic, do advocacy work, social determinants of health work, look into opportunities that will allow you to get more of experience in family medicine. That'll be the biggest thing. In any specialty that you want to apply to, doing more work in that specialty will be the biggest thing that will get you into that specialty. The most frustrating thing I think for us whenever we're reviewing applications, because that's part of our jobs as well when we're residents, is you see someone that did all these things for example, like orthopedics, and then they're applying to family medicine, and it's just like, well, do you really want to do family medicine? So it's really about aligning your CV with what you're looking for.
Yeah, it's pretty easy to see if someone is using family medicine as a like backup option, as Matt was talking about. And I think being able to kind of share a story with your CV. So as Matt said, doing things you're passionate about, and then when you're in the interview process, like being able to tie them together So even though we do a lot of different things and it might seem really piecemeal, I think having like a connecting theme among it can be really helpful, and not getting too bogged down in trying to beef up your CV as much as possible, but doing things that you're really passionate about and do them for a little bit longer.
Okay, so would y'all consider, from Danielle, would y'all consider an additional degree like an MPH? Do y'all think it would be helpful to work in community health leadership? So that's an interesting question. I've had the same question myself along the way. I have found that I've been able to do a lot of community health things without an MPH. I did a master's program in medical sciences after undergrad, just to kind of boost my GPA and my like educational resume, because it wasn't, on par, as some would say, with a lot of places. But I didn't do an NPH by any means. But you can kind of do it either way. If you're really interested in that stuff and you want to work in the public health sphere, for sure you want to work in the public health sphere. It's not going to hurt you. I think it'll only help you. But if you're not really sure, or you think maybe like, oh, I don't really know, I've still been able to get into different like aspects of community health without getting an NPH at any point. So
You could also get it paid for at certain jobs. So I think that's why I went doing it earlier. And then you can use it as a backup option. So if you apply to med school and you don't make it in the first time, you can do your MPH to bolster your CV a little bit. So I don't think it's absolutely necessary to do right away, but definitely would enhance your education. Then we have a question from Sarah, who says, I'm from California, but I go to med school in Chicago, and was wondering if there are any tips about networking with programs back in your home state. So I think that California is definitely one of those places that really wants people that are from California. So I think you have a really good chance of getting back there. And then in terms of what they're looking for, people are really looking for people to invest in their community. So I know that it was really well received when I talked about how I really wanted to stay in Chicago after being here for 4 years, and how I had planted so many roots with all the volunteer work I did. So talking about getting back home and really knowing some of the issues that are really pertinent in your specific state. And then in terms of networking, that's tricky. Do you know ways to do that? I know I'm trying to find jobs outside of here, and it's been hard to network, but I think, again, it goes back to what we were talking about with mentorship, talking about what you want to do. There have been many times where I've said like, oh, I'm kind of struggling to find a job in New York, and someone would like step up and be like, oh, I actually have a friend here, like I can connect you. So I've had many random conversations with people on the phone that have connected me. And sometimes it's like a friend of a friend of a friend who connects me with someone they know. So not being afraid to talk about what you want to do, and reaching out to people back at home that could potentially help you network with someone. People are always willing to talk and help, because it's very hard to get to the top of this position. So people usually want to help you.
yeah, and I would add that if you're looking, so like when I was applying to residency, I was applying both here in Chicago and back home in Boston. So I was, if I do want to go back home, like I was talking about, like, hey, I really want to be back home. I really miss being in this community. I miss doing the work that I was doing here. I've learned a lot in my travels and in my time away, and I feel like it's really helpful and good experience to help me come back home and do the work that I want to do. And that's kind of what I've said, because I'm applying to jobs back home now, and it's very well received to see that someone is like really passionate about their community and wants to be back. That's very, very important.
And then everyone has shared some conferences. I think conferences are a really great networking opportunity.
Yeah.
There's also like different sort of career fairs and networking events that are formal, and you can join those. Sometimes costs, flights, those things are barriers. Sometimes there are virtual options. I know the AFB conference, there is a virtual option. So just going, getting people's contact, and then reaching out to them after. Okay, any other questions before we close?
Okay, I think we will call it. Thank you all for being here with us and being so engaged. And this was really fun. And if there's any questions, anything you want to talk about more, by all means, you have our emails in the chat there. don't forget to fill out this brief survey that Jocelyn's put in the chat, just to help Mola out with these future events going forward. Leah and I both signed up to be mentors, so hopefully we get to chat with one of you all in the future. And if you have any questions, please email us. We'll get this presentation over to Mola and make sure that they get it all out to you. And good luck with everything. This is a really hard process, so please do not be afraid to reach out. Like Leah said, because of how hard it is, there's always someone that wants to help you get there. So definitely reach out, and you'll have 2 friends and the 2 of us. So,
yeah, you all can do this.
Yeah.
Thank you all for coming and for your time. Have a great night.
Bye-bye.
Bye.
Bye. Thank you very much.
Thank you, Jocelyn.